right. Well, welcome to the main meeting for the Rural HPV Vaccination Learning Community. On behalf of the American Cancer Society and the National HPV Vaccination Roundtable, I want to thank you for taking time out of your busy schedules to join us today, whether that's live or via recording in the future. We will be offering live CME and CNE credits for today's session. Like I mentioned, today is part 1 of the HPV Vaccination Communications Duet series that we're doing in partnership with St. Jude. We'll be covering the foundations of the announcement approach in today's session. I do want to note that this program is supported by a grant from the Centers for Disease Control and Prevention of the U.S. Department of Health and Human Services. If you want to go to the next slide, Hannah. So for those that haven't met me, I'm Ashley Locke, Program Manager for Knowledge Translation here at the American Cancer Society. I have the privilege of leading the rural learning community as part of a dedicated team at the American Cancer Society and the National HPV Vaccination Roundtable, working to improve HPV vaccination, cancer screening, and support for rural communities. If you want to go to the next slide. Perfect. So we have a very packed agenda today. In just a minute, you're going to hopefully hear from our HPV-related cancer survivor, Kim Wardshell, who will share her lived experience and help ground today's discussion in cancer prevention. From there, we'll hear from Dr. Noel Brewer, founder of the announcement approach. And then following Dr. Brewer and Maureen Boardman will participate in a fireside chat and talk through Maureen's experience implementing the announcement approach in her clinic. And lastly, we're going to wrap up with some resources and opportunities. So just a few reminders, today's session is being recorded and will be posted publicly. We are providing live CME and CNE credits, and we'll share more information about this in the chat and in our learning materials library. I do want to note that Dr. Brewer does receive a consulting fee from Santa Fe for participating on their advisory board. And this meeting is meant to be interactive. However, we ask that you stay muted during the presentation, but we invite you to use the chat throughout the session for questions and comments. If you want to go to the next slide. So for today's discussion, we'll be focused on the following learning objective, which is really to discuss evidence-based communication strategies to effectively discuss the HPV vaccine with different audiences, including parents, adolescents, and healthcare professionals. You want to go to the next slide. So before I introduce Kim, we're going to just start with a quick pre-session poll. So I'd love for you to share your familiarity and confidence around the announcement approach. A few more seconds here. Looks like we have 65% who have participated. Hopefully we can get to 75%. That would be awesome. You can go ahead and end the poll. And if you would like to share out the results, perfect. So on a scale from 1 to 10 or 1 to 5, how familiar are you with the announcement approach? It looks like majority are not at all familiar or slightly familiar, so that's exciting. I think you all will learn quite a bit. And then on a scale from 1 to 5, how confident are you using the announcement approach? And once again, majority is not confident at all or slightly confident. So hopefully after today's session, you will feel really good about learning the announcement approach and feel more confident and familiar. So we can stop sharing and go forward. So thank you to everyone again who participated in the poll. So we're going to transition to our survivor highlight. So I'd like to introduce Kim Wardshell, who is a HPV-related cancer survivor. Kim's full bio is going to be in the chat, and a way to connect with her will be added as well. Thank you. And Kim, go ahead and take it away.
Good morning, everyone. Give me just a minute here. Okay. A big thank you to Ashley, who kindly asked me if I'd feel comfortable sharing my family's story with you today to provide a real-life example of the value and significance of the work that you do. My name is Kim Wardshell. I'm a public health educator, immunization advocate, and outreach coordinator. The work that I do centers around building programs, partnerships, and relationships that connect people to the preventive care and resources they need. I'm also an HPV-related anal cancer survivor. But before any of these roles, I was a sister, and that's the story I'm here to share with you today. And I can't tell, Ashley, if the photo of my sister is up on the screen, but If it is, what you're seeing is a photo that was taken in the winter of 2016. It's a happy photo of my younger sister, Deb, and me. We were on our way home from one of our frequent visits to MD Anderson and the Houston Medical Center, where my sister was participating in a small clinical cancer trial. Deb had told our family the trial was groundbreaking, specifically for colorectal cancer patients, and she was full of renewed hope for a cure. Less than a year after this photo was taken, my sister would be gone. I would become the cancer patient, and I would learn that the trial my sister had been participating in wasn't for colorectal cancer patients after all. In fact, it was a trial for anal cancer patients caused by the human papillomavirus. In retrospect, my sister had gone to great lengths to hold this information tightly between herself and her providers. I accompanied Deb to her appointments, emergency room visits when she experienced complications from treatment, and even transfusions needed to keep her eligible for the trial. And still, I didn't know. Because we believed Deb had colorectal cancer, several members of our family, including me, were screened for it in the fall of 2017. My colonoscopy revealed something none of us expected, that I too had squamous cell carcinoma of the anus. Before beginning 6 weeks of radiation and chemotherapy, a second biopsy confirmed the HPV strain linked to my cancer. I received my staging and treatment plan the very same afternoon my sister died. We had just celebrated her 50th birthday. Now, I want to pause here because this part of our story is important. For a long time, I struggled with why my sister wasn't comfortable sharing her diagnosis, even with me. But over time, I stopped asking why didn't she tell me? And I started asking different questions. What does it say about our culture that she felt she couldn't? And what can I do to help change that? If you're here today, you're likely aware that the stigma surrounding HPV is well documented, and it can be especially powerful in rural communities where privacy matters deeply, social networks are close-knit, and fear of judgment can feel more immediate than even a potential life-threatening disease. Stigma can drive fear of disclosure, avoidance of care, and underutilization of health services. In rural communities, shame and silence don't just create emotional harm, they can become clinical barriers to prevention and care. More than 8 years later, it still troubles me to think that my sister may have carried shame alongside a terminal diagnosis, that she may have believed she had done something wrong while also knowing she was dying. And beyond the personal loss, there were also missed opportunities to educate our family and our friends about HPV and the vaccine that prevents the majority of HPV-related cancers. During my recovery, I learned more about HPV and the vaccine that prevents HPV-related cancers, and I realized I wanted to do something meaningful with what my family had experienced. That realization led me into public health work focused on immunization initiatives, school-based vaccine programs, and HPV vaccine advocacy, because once I understood these cancers are preventable, I just couldn't unknow it. This November, I'll celebrate 9 years of good health. It's a gift that's tempered by the 9-year anniversary of my sister's death. So for me, the gift and the grief will always be intertwined. And that's why I wanted to share our story with you today, because we know HPV vaccination conversations aren't always simple, especially in rural communities where trust, relationships, and personal reputation matter deeply. We know many parents are trying to do the best they can with the information they have, and often what makes the difference isn't a long conversation or the perfect statistic, but a calm, confident recommendation from a trusted provider. The strategies you'll learn about today, the announcement approach and motivational interviewing, matter because they help create those moments of trust. They help families feel informed rather than judged and supported rather than pressured. And while these conversations may feel routine to you, they can have a lasting impact on the families sitting across from you. I often think about what might have been different if HPV-related cancers had been discussed more openly in my sister's lifetime, and if prevention had been as normalized then as we're working to make it now. And while we can't change the past, we can absolutely help shape what happens next. So Thank you for the work that you do and for allowing me the opportunity to share my family story with you today.
Kim, thank you so much for being a part of today's session and for sharing both you and your sister's powerful survivorship journey with us. Your openness and willingness to speak so candidly helps to anchor this work in real lives and real impact. And your story is a powerful reminder of why efforts to increase HPV vaccination in rural communities are so important. So thank you. We are really, truly grateful for your time, your courage, your leadership, and your continued advocacy, and for sharing, with us. So thank you. We are now going to move on to our didactic presentation for today, which will be led by Dr. Noel Brewer. Dr. Brewer is a Gillings Distinguished Professor in Public Health and member of the Langberg Comprehensive Cancer Center at the University of North Carolina. Dr. Brewer's full bio will be added to the chat, as well as a way to learn more about his work. I do want to just note that Dr. Brewer does receive a consulting fee from Sanofi for participating on their advisory board. So Dr. Brewer, go ahead and take it away.
Hi, folks. Thanks for having me today. And I really appreciate Kim taking her time to share her personal experiences that make all of this work especially real. One of the policies I've always had is when we do our trainings on communication, we always start with someone's story. And that's what's embedded in the Announced Approach training that I'll be talking to you. It says the things you've heard a couple times. I also have federal funding, as well as I've received funding in the past from industry sources, as well as from nonprofits. So our desired outcome here is to encourage healthcare systems and even individual providers to attend an HPV vaccine communication training or host one of the clinics. So the specific objectives are to understand the impact of HPV vaccine for cancer prevention, describe the 3 steps of the announcement approach for HPV vaccine communication, and to identify resources for bringing the announcement approach training to your office or healthcare system. So let's start with the review evidence part. So we know that HPV causes 6 cancers, and we heard about anal cancer just now. But what many people have lost track of is that oropharyngeal cancer is by far the most common HPV cancer now, and it's happening in men. And so we often think of HPV being as synonymous with cervical cancer in women, but it's affecting both men and women. Another important fact is that at least cervical cancer is more common among Black and Hispanic people, so the people with cervix. So we should also keep track that these cancers are not equitably distributed across society. They affect some groups more than other groups. HPV vaccine is really effective. It's one of the most effective vaccines that we have, and it's allowing us to think about the near elimination of cervical cancer. And that's wild to think about a cancer actually ending, and maybe ending in our lifetime, at least as a public health problem, so that its rates will drop dramatically. Here's a study that came out not that long ago that's showing among folks who never had HPV vaccination, they have a rate of somewhere over 90 invasive cervical cancer cases per 100,000 adult women. However, if they received HPV vaccination as an adult, it drops. And then if they got it as an adolescent, there's an 88% decline in cervical cancer. And that's amazing. We're already seeing extraordinary impact of the vaccine across many different HPV diseases. HPV vaccine is also really safe. There's been over 300 million doses delivered in 109 studies of 2.5 million people. They found the only serious adverse effects were those also seen for other adolescent vaccines. So this is a super safe vaccine that's also tremendously effective. Now, the guidance on how many doses to deliver and all that are really a matter of a lot of discussion right now. We saw the CDC had a new schedule, and then it was paused by some legal actions, and it's a bit confusing. However, for right now, the recommendation is, as the label indicates, 2 doses of HPV vaccine delivered somewhere between age 9 and 12 years. And if people miss that window, then they can go on and get it at least by their 14th birthday. Now, if they miss that time, it'll be late, but they can still get it. If they miss that time frame at ages 15 plus, then it's best to give a third dose. There are discussions about single-dose HPV vaccination, including a really promising trial out of the National Cancer Institute, and the American Academy of Pediatrics is considering updating their schedule regarding the number of doses. And just keep your ears out. You should hear from them in September regarding recommendations that will take effect starting in January. And I should also disclose that I'm a member of the committee that will be helping to make those recommendations. The vaccine is especially effective in younger children, and that's why the recommendation is to start at age 9. It's also important to use the language starting at age 9 because it helps providers know that we're not talking about maybe, possibly. We're talking about, yes, absolutely, you now, let's go, let's get started. So let's now turn to talking about the announcement approach training. So what is it? Well, it's a training on effectively recommending HPV vaccine to patients. It's for providers, but it's also for nursing staff. And we'll also include MAs and other folks there. Anyone who interacts with a patient can take this training. And what we found is about 3/4 of people who take the training are nurses or MAs. But then again, of course, the other quarter is typically physicians or maybe other providers. It's a 60-minute training, typically done live in clinic. It's led by a person with experience providing adolescent vaccines, typically a physician, but it could be a senior like a nurse practitioner or a very senior nurse who has a lot of experience and has that gravitas. And you know what I mean, that when that person walks in the room, all eyes look at them and they look at them and think, I'm going to listen to what this person's talking about. The announced approach training is now an NCI designated best practice, meaning that it's been shown to improve vaccine uptake. Okay, there are materials available online at hpviq.org. There are scripts and slides, they're standardized, you just pick them up and you can use them. There's demonstration videos, and there's also a flyer that can be used to provide to give to providers and other clinical staff. So there are various benefits of the training to clinical staff. It boosts HPV vaccine uptake by 5%. There's not a lot else you can do in an hour that's going to get things going so much better. And that's a really lovely thing about this, is that a randomized controlled trial that I conducted has shown that. And then other observational studies since then have also shown improvements. It simplifies discussions. The announcement approach simplifies discussions and saves time. It cuts the time to discuss with patients by about half. So it typically takes maybe 3 or 4 minutes, and it cuts it down to maybe 2 minutes. That's in people's impression. If you actually look at the recordings, it's even half of that. So it cuts it down to maybe a minute, minute and a half. Patients are more satisfied. Patients are more at ease. They like what's happening. They like that they have some flexibility in and they have a say in how the conversation goes. It's also equally effective for nurses as well as for physicians. The CDC, well, the old CDC, I don't know these days, maybe they do. The CDC and the American Academy of Pediatrics recommend using presumptive announcements, which is one of the techniques that we show. The AAT has been used nationally. It's now up to 12,000 people. 12,000 clinical staff, including physicians, have attended in over 20 US states. It's also been used internationally. As I mentioned, there's high satisfaction. 100% of attendees would recommend the training to a colleague, and 93% plan to routinely use the communication strategy. Even when we don't have our fancy, extra trained presenters doing it, when we have done a train the trainer, the ratings are typically high like this, including in rural areas. One of my favorite quotes is shown on the slide that I just went past. This is from an attendee. It's easier for parents. It's easier for us. It just makes it easier on everyone. It saves time and improves satisfaction. So let's now talk about the announcement approach itself. It starts with an announcement, which I'm going to describe. Then, if a parent hesitates, you'll move on to connecting and counseling. And then if you hear a no, probably a firm no, and not that often, but you may hear it. If the parent declines, then you're going to try again at a later visit. And we'll tell you a bit about how to make that happen. So let's start with the announcement. You note the child's age. And this noting the child's age helps to create a norm or an expectation that everything that follows is just part of routine care. You then announce that children this age get a vaccine that prevents 6 HPV cancers. What's really important is we're not talking about HPV vaccine. You're going to say she's due or they're due for a vaccine that prevents these cancers. So focus on the benefit and how it helps their health. And then the next piece, which is very important, is you say you will vaccinate today. That's extremely important. It helps the parent know that we're not talking about maybe one day or just getting you used to the idea. Instead, you're saying, I'm recommending we do this today. It's time. Let's go. Here's an example. Alex is now 9. So today they'll get a vaccine that prevents 6 HPV cancers. That's it. It's really brief. Then you pause and wait to see what happens. Maybe they have questions. So if they have questions, you're then going to connect with a parent. No matter what they said, if they said, no, I don't want it, or I don't know, I heard something, but I'm not sure what, you come back and you ask them because they'll have a chance to organize their thinking a bit. And you'll say, well, what's your main concern? Our experience is that until you get the main concern on the table, nothing else can get done. You'll deal with all the little things that they don't care that much about, but the big one that's really weighing on them is the thing that's going to drive the conversation and is driving their decisions. Then, no matter what they say, to show you're listening, you're going to repeat the parent's words. Use their own language insofar as you can. If it feels too spicy to you or just a little too much, then you can shift over to saying something like, well, we both care for your child a great deal. We want the best for your child. That's what we're about. You as the parent, me as the healthcare provider. So what would you say is your main concern? Well, I thought that they wouldn't need any vaccines for a few years. All right. So now what do? I hear you. You didn't expect Alex to be getting vaccines at this visit. And that's a fair comment at age 9 or 12. I mean, parents I thought all that might be behind them. All right, so now we move on to the counsel part of the Connect and Counsel. You address the parent's concern using a research-tested message, and we provided those that have been tested with healthcare providers and also with parents and found to be the shortest way to get to yes, a simple accumulation of a few ideas that will get to the main point. Now, I will say this. It's important to elaborate a little bit. We've given you the heart of the message, hopefully something you can remember. They're meant to be something you can memorize. But parents like longer messages. We gave you short ones, but the ones that test best are a little longer. So elaborate to make it 2 or 3 times that length. So clearly recommend getting HPV vaccine today and give a reason. So here we go. The American Academy of Pediatrics recommends that kids get the HPV vaccine starting at age 9 to prevent 6 cancers. I strongly recommend Alex get it today because the vaccine works better when given younger. So now, hopefully that's all going to work. And sometimes it doesn't, just fine. You don't need to spend all of your day with that patient who's not ready at this moment. 3/4 of parents who say no, who fully decline the vaccine, are going to get it within the next year or intend to. So a no doesn't mean a lot. It just means no for right now. It's not a threat to you. They're not questioning your authority. They've just, for whatever reason, are firm. They're not going to do it today, and that's fine. So what you can do is you can say, good, we're going to bring it up again at the next visit because this is really important, but let's move on. And then you're going to make a note in the chart for you or whoever sees the child and the family the next time for a well visit or an acute visit to bring it up again. All very simple, very straightforward. Now, I saw that some of you have read about the announcement approach or have some familiarity with it. Most of you didn't, but some of you did. So I want to tell you a bit about some of the updates that have happened over the last couple of years. So we modified the steps that combine Connect and Counsel into a single step. And we've also added Try Again because that turns out to be a really important thing, that coming back to it is increasingly necessary. In the good old bad old days, whatever, when patients would just do whatever a healthcare provider said, then it was perhaps a bit different. But now people often want to have a bit of back and forth, and sometimes they need some time to consider. Another change is the focus on age 9, which follows a national push to start HPV vaccination younger. There are a lot of benefits to starting at age 9. They're more likely to complete. The vaccine may be more effective. It's very effective, but it may be even especially effective starting at age 9. And the announcement step focuses now solely on HPV vaccine at age 9. There's a slightly different way you can do it at age 11, where you probably have other adolescent vaccines, including meningitis and whooping cough vaccine to deal with. So it focuses on inclusion. We highlight the impacts of HPV on communities that are most affected by the disease. We give we give an example that you just heard of an announcement for a non-binary patient. And we use names for children that are common in multiple communities. And then finally, the demonstration videos that I'm about to show you also are more inclusive in their representation. And in this way, they look a little more like the patients we see day to day. All right, so we've also added demonstration videos so folks can see what this looks like in practical terms. The old one was one that was shot in my kitchen with a friend who was a physician and then a project manager. So this is we improved our game a little bit. So let me get this started.
Now that Marcus is 9, it's time to get started on a vaccine to help protect him against 6 HPV cancers. He'll get his first dose today and his second one at his next checkup.
HPV vaccine for a 4th grader? Wow, I wasn't expecting that.
Okay, it sounds like you have some concerns about that. Can you tell me more? What would you say is your main concern about the HPV vaccine?
Isn't he too young? My older daughter didn't start that one until she was 12.
I hear you. It is hard to believe that Marcus is old enough for the HPV vaccine. It probably seems like just yesterday you were doing his booster vaccines to get ready for kindergarten. But 9 is actually a great age to get started.
Really? Why is that?
Well, for one thing, kids have a stronger immune response to the HPV vaccine when they're younger. That may give them better protection against HPV cancers later on. Another advantage to starting now is that Marcus still has plenty of time to get both doses at his regular checkups. That way you don't have to bring him in for extra checkups.
Okay, if you think it's time, we'll go ahead and get started.
Great. So Marcus will get his first HPV vaccine today. At his next checkup, we'll give the second one, and then he'll be all set.
All right, well, that went pretty easily. And that was for our 9 to 10-year-old. That's using the HPV cancers introductory language. Now let's move on and do the second one, which is what it would sound like for an 11 or 12-year-old. And this one is a little more complicated, a little spicier. Oops, we went right by it. Sorry, I'm in charge of the slides and I'm not operating them well. Let's try again here. I'm not succeeding. Let me see if we can. There we go. Thank you.
Now that Sophia is 11, it's time to give her vaccines to protect against meningitis, HPV cancers, and whooping cough. We'll give those at the end of the visit.
Yeah, I know she needs to get some vaccines before school starts, but HPV vaccine? I don't think we need that one.
Okay. It sounds like you're not sure about the HPV vaccine. Would it be okay if we talk more about that?
Yeah, okay.
What would you say is your biggest concern?
I've seen some bad stuff online, like that HPV vaccine can cause infertility and that kind of thing. I just don't want to risk it.
It makes sense that you'd be concerned about those stories. The good news is that researchers have conducted over 100 studies on the safety of HPV vaccine. They've consistently found that it's really safe, just like the other vaccines we give at this age.
Okay, but what about fertility?
Many studies have looked specifically at fertility, including ovarian health. The findings are reassuring. There's no evidence that HPV vaccine causes infertility or any other reproductive health problems. What can cause infertility is cervical cancer, which Sophia would be more likely to get if she's not vaccinated.
Yeah, I don't know. I just don't think the HPV vaccine is right for our family. I would need to talk to her dad before making a decision like that.
I hear you. Today we'll do the Tdap and meningitis vaccines. I'll put a note in her chart and we'll revisit the HPV vaccine at her next checkup after you've had time to talk to her dad about it. I want Sophia to have every opportunity for cancer prevention, so let's keep talking about it.
Okay, that sounds good.
Okay.
So for those of you who work clinically, you'll recognize the second patient and maybe even the first one. not all conversations are easy ones, but this one didn't have to be. It wasn't at high volume. It was brief, it was very respectful, and it continued to build the relationship between the family and the provider. Okay, so what else is new is we have a technology-assisted practice session that delivers vignettes and roles for the attendees to practice the announcement approach. And it also streamlines access to the flyer that describes the messages that providers can use. We also now have a facilitator orientation that reviews the evidence behind the training and builds facilitation skills and understanding the facilitation logistics. Here's the team. I specifically want to call out Melissa Gilkey, who's developed the announcement approach with me over the years, and then now more recently, Dr. Jessica Young, who's been just an outstanding clinical collaborator. So let's now talk about putting the AAT to use, meaning the announcement approach training. Here are some testimonials. So Kenneth Alexander is the chief of the Division of Infectious Diseases at Nemours Children's Health in Orlando, Florida. And here's what he had to say. The announcement approach makes the communication process shorter and more efficient. It makes us more willing to advocate for vaccination, and it gives the whole process a more positive tone. Another benefit is that we see more families making the right decision to vaccinate. It was a great project that's a lot of fun. Having led the training for several groups, I can strongly endorse it as a teaching opportunity and as a learning opportunity. We also worked with a very large healthcare system in the middle of the US. And this QI person who has to be, whose name is confidential because of the policies of the healthcare system. It was a huge deal for our healthcare system and clinics, not only for all the education it provides, but it has also been a great team building exercise. The research team encouraged us to make sure everyone was given the opportunity to speak up, so our MAs, LVNs, and RNs, as well as our providers, are talking and engaged. A nice thing that I'll also mention is getting everyone talking at the same time allows people who have more skills in the area to share the skills and understanding with those who are new to it, or maybe are using something that's a little old school and are reluctant to change. It can help set the norm for what the senior and most powerful people in the clinic want to do, and that can help then trickle down all the way through the power structures in the clinic. So how do you bring it to your colleagues? Well, you can engage your healthcare system by meeting with senior decision makers in quality improvement. And then you would usually identify a champion to serve as an AAT facilitator, as well as staff or administrative support. You would then host an AAT workshop in your clinic or across multiple clinics. And you would attend the facilitator orientation if you're going to lead it. And then you would get materials from us and then plan the logistics and have a great workshop. So how do you get the materials? You can visit hpviq.org. It's a site that I helped host along with Dr. Melissa Gilkey at UNC. And do we offer continuing education credits for the workshop? No, we don't, but you can. And when we do it ourselves, we are able to do that. So if you would like to offer it, you would just do whatever you usually do to get continuing education credits. And it's pretty easy because we already have all the materials you'd submit. There's the slides, there's a script, very straightforward. All right, and with that, we'll wrap up. Thank you so much.
Perfect. Thank you so much, Dr. Brewer. That was so informative and a really great overview of the announcement approach. So we're now going to transition into our fireside chat. So Dr. Brewer will be joined by Maureen Boardman for a candid conversation about Maureen's experience implementing the announcement approach in her clinic. So what it looked like in practice and what she's learned along the way. But before bringing Maureen into the conversation, I thought I'd ask Dr. Brewer to start with what initially inspired you to develop a training approach like the announcement approach?
Well, I've been hearing from my physician colleagues and other people in primary care that talking about vaccines was hard, and talking about this particular vaccine was especially hard. So with childhood vaccination, there's just this big runway with lots of vaccines at very early ages, and everyone's kind of used to that. They get into the rhythm of it. But all of a sudden, a vaccine comes up at age 9 or 12, and everyone's thrown a little bit. And then there's this vaccine that feels new, HPV vaccine. In fact, it's older than your iPhone. It's been around for forever, but providers were a little thrown and parents were a little thrown. So we wanted to do something that would make providers' jobs easier help people understand the value of the vaccine, and most importantly, improve vaccine uptake.
Perfect. Thank you so much for sharing. So I will go ahead and let you guys have the fireside chat, and we'll be here to listen.
Hi, Maureen.
Hi.
I have to ask you, on top of your bookshelf are these little figurines. Can you tell me what they are?
Oh, they're the little willow tree angels. Um, Somebody bought me one, and then patients coming to my office saw that there was one, and so now I have a whole collection of them.
You have a whole choir of them now.
Yes, I do.
Hmm.
So,
Well, how do we start? And I'm not sure what the role is here. My role is here, and I'm sorry for not being up on that.
Oh yeah, no, it's okay. Maureen, I don't know if you want to tell us when you first heard about the announcement approach, what made you interested enough to try it in your practice?
so I've always been very proactive regarding vaccines, particularly the HPV vaccine. But the my vaccination proactivity started because I'm the daughter of a childhood polio survivor, of a mom who spent a lot of her childhood in a children's hospital. And so I was lucky enough to be at Dartmouth at about the time that the HPV vaccine was being developed. And one of my colleagues, Diane Harper, who's an MD, has now left Dartmouth and moved on. But was instrumental in bringing the HPV vaccine to market. And so I thought, this is wonderful. We now have a vaccine that prevents cancer. So it's always been an interest of mine. A research friend of mine at the University of Massachusetts at Amherst, who knew my interest in the HPV vaccine and some of my research around the HPV vaccine, actually reached out to me about this approach, and asked me if I would be willing to be trained in the announcement approach and then teach it to a New England Rural Health Medical Nursing Student Summit that they had last fall.
Very interesting and very, I like how you shared your story. So can you talk to us about how you implemented the announcement approach in your clinic or office?
So it was interesting to hear Dr. Brewer talk because I wanted to make sure when we did the training that we included not only clinicians, but the nursing staff, because they're the ones that are rooming the patients. And oftentimes I found that, the MAs, RNs, LPNs, whoever is rooming the patient will come out and say, hey, that mom asked me like what I did, or did I have my children vaccinated against HPV? And so I felt it was really important that the whole clinical staff was on the same page.
That's such a great point. I think Dr. Brewer, you mentioned that, right? With another system that included all staff so that everyone was on board and was delivering the same message. So that's
This is something we do for all of our trainings, at least if I have any role in it, is we make sure everyone gets involved. Sometimes they even have the front desk folks, but that's up to you. But regardless, nursing staff run clinics. We need to make sure that they're part of communication as well. One little sideways, oh, and there's this other vaccine, eye roll, you're done. There's no one doing that. So if they have some concern, they can set it aside, or maybe they can just learn to be more comfortable with the vaccine and provide communication about it in a much more compact and easy way for everyone.
Yeah, for sure. Maureen, I don't know if you want to share with us, how did HPV vaccine conversations look like in your clinic before you started using the announcement approach? And I guess now that you are trained and all of your staff is trained, what are you experiencing now? And how has that approach changed, I guess, conversations?
We as a clinic have always been pretty proactive around the HPV vaccine. And so we haven't had, I don't think that the conversation has changed all that much. think the one thing that the announcement approach has taught us is to let the patient sit with the parent, the family, whoever is bringing the child in, to let them sit with the decision for a while, that it isn't something, particularly if you're starting at 9, but even if you're introducing it at 11 or 12, that there is time to get the vaccine in before you have to give the extra, an extra vaccine dosage. And so letting the parent or family member sit with the decision. And sometimes, I often have literature that I often offer the parent to read about the HPV vaccine and its success and safety. Because I find that's a lot of the parental concerns. As Dr. Brewer alluded to in his talk, there's a lot of false information out there on social media and the internet about the HPV vaccine, among others. And so being able to address those in the room with the family, but also then giving them some literature to take home with them.
Perfect. There's a question in the chat, and Dr. Brewer and Maureen, if you guys both want to chime in. But with vaccinations being a really hot topic now in the current political environment, how are you recommending or addressing that resistance based on what they're hearing either in the news or social media with from our government leaders? I don't know if you both would like to share.
It's a wild time for vaccines because there's so much in the news and there's so much noise around them. It's hard to get to the bottom line of what are parents really thinking. There's still a lot of support. Most parents support vaccination and supported by a lot. So vaccination is still widely popular in the United States across the political spectrum in rural and urban areas. And whatever your political orientation is and whatever else. Now, that said, there are challenges. And one of them is that some people let's say on the right, they don't like vaccine requirements. And that's fair, right? We can disagree on that. Like some people might be pro that and anti that, but that's not the same as the vaccine. There's still broad support on both ends of the political spectrum for HPV vaccine. So we shouldn't shy away from it. Now, it is true that in rural areas, HPV vaccine uptake is a little lower and has been about 10 percentage points lower. It's unclear whether that's reflecting any deep beliefs that people have or just the challenges in trying to get pediatric care done in rural areas. There are a lot of barriers that are faced, and some of those are solved in urban areas with centralized clinics and large population centers and more providers and all of that. So I think you can just go straight on ahead, not shy away from vaccines. And if it comes up, if you run across someone who's really upset about some aspect, you can have a conversation. I will say that even the modified vaccine schedule that CDC tried to make happen had HPV vaccine as a recommended vaccine. So even in that sort of context, which is maybe iffy according to most experts, it was still considered one of the most important vaccines for children to get.
Perfect. Maureen, what are your thoughts as a provider, and what you're hearing from patients and their families?
Yeah, I feel like I am lucky that where I practice, I have not experienced a whole lot of vaccine resistance against the HPV vaccine or the other childhood immunizations. However, I just recently looked at some data showing that in my state, which is Vermont, the vaccination rate, the latest figures, I think they were for 2024, showed that the HPV vaccine for 13 to 17-year-olds completion rate was around 58%. And looking at the Tdap and the meningococcal, which are the other two vaccines that we give around that same age, those are up around 90%. So obviously there's still some, resistance and hesitancy regarding the HPV vaccine. So I feel like I think we just need to continue to work with patients, families, and parents and educate them around the safety concerns, because I think that's what it usually boils down to.
And I'll add, and I think it was implicit what Maureen said, and we'll communicate in a way that maintains the relationship. The relationship of you to the patient is far more important than any one vaccine. This will happen over time, or maybe it doesn't, but what's most important is that trust relationship that you've built over so many years.
Right, absolutely. Um, Dr. Brewer, there's a couple of questions coming in the chat around the anticipation of a single dose of HPV vaccine series. How is that going to affect the announcement approach? I don't know if you have any thoughts around that or want to share.
Yeah, the announcement approach is really focused on initiation because I've always believed, and the science says, that the first dose is where most of the benefit comes, maybe all the benefit. We don't know for sure right now, but that sure looks like that. So the first dose is what we should spend all of our time focusing on, and the announcement approach is well suited to recommending it for that first dose. For additional doses, it can also work. And that's fine. We'll know by the end of summer whether we're going to a one-dose schedule according to the American Academy of Pediatrics.
Perfect. Dr. Brewer and Maureen, I don't know if you have anything that you can share around the difference in parental hesitancy between rural and urban in the US. Like if you've seen anything or any trends that you may be able to share with the group.
I think that sometimes, as Dr. Brewer alluded to, rural vaccine hesitancy doesn't necessarily boil down to just vaccine hesitancy. It's transportation issues. In urban areas, there's much more public transportation available. And so things like that impact kids staying on vaccine schedules because they can't always get to clinic offices for their routine wellness visits because of transportation. And it's a huge issue all across the country in rural areas.
I think I agree completely with what Maureen just said, that we don't, even if you can demonstrate some differences in hesitancy, it's not where the main issue is. It's all about the most basic things about access and insurance coverage and those sorts of things. If there is a difference, rural folks are maybe a little more self-sufficient, and they don't always warm to strangers. I spent a couple of years living with my grandmother in a very rural part of Massachusetts, and there's just a different way that people in rural areas are, and it's about the people you know, and those are the people you trust. So healthcare providers are those people that you trust. Someone like me coming sailing in there, I'm not a trustworthy person in those kinds of places, and that's perfectly fine. You work with local leaders who are trusted and who are part of the fabric of the community.
Yes, like the weavers, right? I've heard that term before, working with the weavers and the people who are trusted. On that same note,
I'll say work with the farmers. You get a farmer on your side and you've got your whole problem solved.
right, for sure. Kind of going along those lines, Maureen, how has the announcement approach training helped you respond when families aren't immediately on board without damaging that trust that you have, with your patients and their families?
I think it's just helped me to realize, as Dr. Brewer said, that, that this vaccine, any vaccine is not worthy of offending people to the point that they, don't want to come and see me anymore. And so I think that it's let me realize that I can take a little bit more of a low-key approach and say, we'll revisit, okay, I hear you, you're not ready at this point, but I am going to bring it up at, the next, child visit and see if you've given any more thought to it. And it's caused me to do it with adult vaccines as well, being family practice. I just revisit. They say no to the shingles vaccine, and when they turn 50, and I come back at 51 and say, shingles vaccine.
Yeah, perfect. Dr. Brewer, did you have something to add?
Yeah, just that we, with the big measles outbreaks we're having all across the country, that the measles vaccine is pretty urgent, and it's a matter of life and death, or at least hospitalization, all sorts of other things. So you just pick your battles. And with measles vaccination, maybe you go to the mat, or maybe you go a little far and you sort of move into an uncomfortable place. With this vaccine, there's no need. You have time, as Maureen was saying, and you do it carefully, slowly over time, and it would be better at a younger age, but start at age 9, and you'll have a couple of years to go at it.
Perfect. We're getting a couple of questions into the chat. And Andrew just asked if either of you have any suggested language or sound bits for that try again approach. So if someone is resistant and they're not necessarily on board right now, what is a way to keep that conversation going? I don't know. Maureen, if you want to take it, and then Dr. Brewer as well.
I just say something like, I hear you. It sounds like you're not ready to consider the HPV vaccine. And, if they're interested in if safety is a concern, then I have some literature ready. And if they just want to think about it, and I just say that we'll revisit it, the question about the vaccine at their next wellness visit.
I think that's great. And any language you use, the key things are saying you want to come back to it because it's important, and you are going to come back to it. If you want some language, there's a little bit of language in this article, scientific article that I put in here. If there's a paywall issue, we can get a copy to folks. There was also an example that was in the video that we just shared.
Perfect. There's quite a few questions about the single dose. And Dr. Brewer, I don't know if you have any information that you could share about when possibly single dose may be available, and do we anticipate that the AAP is going to limit recommendation single dose to female populations?
I can't speak to their deliberations, they're ongoing. There is no appetite in the US for returning gender or sex to part of the conversation about HPV vaccination. We want a gender neutral vaccine, and that's the best way to do this. So there's no limiting in that regard, as I understand it. And if there's a shift to one dose from the multi-dose schedule, it's because it's just as effective. So we're going to save those resources for some other purpose. But there's no limiting, if you know what I mean.
Thank you. I appreciate that. Maureen, can you speak a little bit more on language you use at the next encounter when someone's already expressed resistance? So you've recommended it once, and you've said, we'll talk about it again at another visit. I guess, how do you reapproach that subject with them?
So I usually say something like, so at Johnny's last visit, we discussed HPV vaccine, and you wanted to think it over. You had some reservations. So I wanted to bring it back up because I believe that the HPV vaccine is very important to his long-term health, and see how you feel about it, and if there's any other information that I can provide for you and how you're feeling about vaccination today.
And I especially like what Maureen did there by asking for them to speak. When people speak, they can then listen. So she sort of left the breadcrumbs out there, or left set the table and said, let's sit down, let's have a conversation. It doesn't have to be 20 minutes. It's going to be another 2 to 3 minute one, but see what they have to say, and then you can pivot and respond to that. The other thing I'll mention is that sometimes what happens is that a parent will say they have a concern and just fill in the blank, and it's a bit exotic, and you don't really know exactly what the science says. It's probably not true, but you really want to be sure. So you say, well, that's a really good point. I want to come back to you, and I'm going to get you the information you asked for. And then you can do that at the visit, or maybe you'll do it through the patient portal. Don't worry about saying, I'll answer your question later, but that's just part of this ongoing thing. So sometimes the reason for the delay will be because you don't know about this exotic thing that they brought up that probably isn't supported, but still you need to be sure because you want to be a credible source of information.
That's a great point. Thank you. Thank you, Dr. Brewer and Maureen, for such a thoughtful and practical discussion. We really appreciate you both sharing the evidence behind the announcement approach and what it looks like when it's implemented in real-world clinical settings. So thank you both for being a part of today's discussion. We're going to now wrap up today's session and do a quick poll and share some resources to support your work and talk through next steps. So if we want to go to the next slide, while you're taking the poll, I will continue on with the conversation around resources and next steps, just so that you all can, we can get off on time. So if you want to go ahead and launch that poll for me. Perfect. And then in the meantime, Hannah, if you want to go to the next slide. Perfect. Okay. So in case you've missed our email or any previous sessions, we have a new landing page, which is now live on cancer.org within our knowledge translation section of the American Cancer Society website. This page includes background on the ARC network and our knowledge translation work. And as you scroll down, you'll find the Rural Learning Community Hub. So this is your central place to register for sessions, access recordings and slide decks, explore our resource roundup, and revisit any materials at any time. So we encourage you to bookmark and share the page with colleagues and partners. My colleague Brianna has linked it in the chat. If you want to go to the next slide. So one of those tools that's on the Rural Learning Communities Hub is our Rural Learning Materials Library. So this is your central hub for everything from session recordings to slide decks and CME and CNE info sheets for each of the sessions, dating all the way back from when we started, which was in 2024. So you can find 2024, 2025, and 2026 sessions. If you want to go to the next slide. Another thing you can find on that central hub is our resource roundup, which serves as that one-stop shop for ready-to-use tools. You'll find a wide range of HPV vaccination resources, including continuing education, quality improvement templates, and even communication resources, which I have put here in the slide deck. We're continuing to build and refine these resources and are recently updated to improve its flow. So if you have a resource that you would like to share and have featured, please feel free to reach out to me or drop it into the chat and we can make sure to do that. If you want to go to the next slide. Going to go quickly through these. So included in that resource roundup is a link to our HPV vaccination social media toolkit and our HPV communications toolkit. Next slide. Both of these resources can be used to support a strong HPV vaccination recommendation. So definitely check them out. If you want to go to the next slide. So as we wrap up today's session, we encourage you to take a few clear action steps. Start by using the announcement approach with every age-eligible patient and practicing it regularly to build confidence. Align your care team on shared language, bundle HPV vaccination with routine adolescent vaccines, and identify where this approach and opportunity fits best into your workflow. Designate an HPV champion to model the approach, document any refusals or delays, and plan for follow-up and reminders. And finally, be sure to join us for part 2 of the communication duet series to strengthen your skills in responding to questions and hesitancy. If you want to go to the next slide, this particular slide has more information on part 2 of our HPV vaccination communication duet, which will take place tomorrow, May 14th. The session will provide insight into motivational interviewing and ways to overcome hesitancy. Please feel free to scan the QR code or use the link my colleague Brianna has added to the chat. There will be live CME and CNE credit given as well. Next slide. We have a new program through our QI Resource Consulting Program, or QUIRC for short. It's a no-cost quality improvement coaching service for cancer centers and primary care systems, serving disproportionately affected populations. So teams receive data-driven QI support focused on solving real cancer-related patient access and care challenges. This could also include HPV vaccinations. So Brianna has provided a link to the program overview. If you're interested in applying, you can scan the QR code or click the link in the chat. The application does close on June 30th. If you want to go to the next slide. Along those same lines, I'm excited to share that Humana, along with the American Cancer Society and St. Jude, are partnering for an upcoming announcement approach training. Participants will receive 1.25 free CE credits for clinical teams. However, to participate, you must be located in the following states: Florida, Kentucky, Louisiana, Ohio, Oklahoma, South Carolina, Virginia. So if you are in one of those states, you can scan the QR code or click the link in the chat to sign up. And last slide, I want to thank you all for joining today's session. We look forward to seeing you again on June 10th for a panel discussion on small media and HPV vaccinations. Until then, thank you for everything you do to support rural communities.